going to, if it's okay, I'm going to turn off my camera. Okay. Can everybody hear me okay? Can I get a thumbs up? Can you guys still hear me? All right, awesome. You go ahead. You look like
Yeah,
you're about to
sure.
say something.
Yeah, I'd love to do an introduction.
Sure, that'd be great.
Welcome, welcome everyone. Good afternoon. It's my pleasure to introduce Dr. Ursula Guillen. I hope I've got your name pronounced correctly
That
there.
was perfect.
Good. Dr. Guillen is a neonatologist whose work has focused on some of the most challenging aspects of neonatal care, the communication with families, shared decision making, and counseling at the limits of viability. Her research helped advance our understanding of how parents process complex information, how we communicate uncertainty and prognosis, and how we can better support families making difficult decisions before and after birth. And her work has been influential in shaping conversations around periviability counseling and family-centered care. And today, Dr. Guillen will share her perspectives and her experience in this important area. And we're grateful to have her with us and look forward to learning from her. Thank you very much, Dr. Guillen.
Thank you so much for that kind introduction. Good afternoon, everyone. It is 2 o'clock for you, 5 o'clock for me. I will give you a heads up that I am in my office, and every now and then my computer decides that the microphone is no longer going to work. So if that happens, please stop me, speak up, and let me know. It's usually a quick fix, but it doesn't alert me when it does happen, and it happens at random. But let's get started. So my objective for today is to discuss decision making at early gestational ages. And within that, I'd like to start a conversation about the limitations we currently face in neonatology. These are limitations that need to be addressed as we support families who are making complex medical decisions. And I hope to share with you a way for us to support values-based decision making at periviable gestations. I have Come on, advance. There we go. I have nothing to disclose, but some of the work I'm presenting here was supported by an IDEA grant, a REACH grant, and
Dr.
by the
Guillen, I'm just going to jump in and double check that you've tried to advance the slide. Oh, okay. For me, it just now advanced. Sorry
Oh
if
my.
I don't know if I'm the only one on a delay. Sorry, but I just now saw the switch to the second slide.
Okay. So we might have a lag, and I apologize. All right. We'll power through. Technological
I'll
difficulties.
jump in if I see any other issues, but I
Okay.
think we're okay.
Thanks. All right. So we are going to start with a case. You're called to OB triage or OB, labor and delivery, wherever it is that moms present for you. And there's a 19-year-old woman. She is a G1P0. She's presenting with a bulging bag. She's had limited prenatal care. She's actively contracting. She has an uncertain last menstrual period that puts her at somewhere between 23 and 24 weeks gestation. She got betamethasone about 30 minutes ago, and she has magnesium that is currently running. And your OB colleagues say, please go talk to her. She says she wants everything done. And I want you to think about the following. How do you counsel this woman? What are the potential barriers to effective counseling? We can very quickly list off a handful of barriers, such as the timing for the discussion may be limited. There's uncertainty in her dates. She's getting magnesium and she's potentially drowsy. She could be in pain because she's having contractions and can't hold a conversation. There's the potential for stress, her own stress, your own stress. But I want you to think about biases. what biases are potentially present? Does it matter to you that she's 19? Would your counseling be different if she was 40 and on her 5th round of IVF? Would it matter to you if she's married or single? Would it matter if this pregnancy was planned or unplanned? What information does this woman need in order to make an effective decision? An effective decision is one which is consistent with one's own values and is acted on. What information does this woman want to receive? We may have an idea of what we think she needs to know, but what does she actually want to know? And before I continue, I want to be very clear. There isn't a correct decision that a woman or couple needs to make. It is not our job to convince a family to choose a specific option. Equally loving families may request an attempt at life prolongation with neonatal resuscitation at the time of delivery, or they may choose to allow a natural death to occur. Everyone facing this decision wants to make the right decision for themselves, and it's our job to equip them with the right tools to make the decision that works for them and is consistent with their values. In the United States, periviable births, defined as a delivery between 22 weeks and 0 days to 25 weeks and 6 days of gestation, occur in about 0.4% of all deliveries. And these births make up about 40% of all neonatal deaths. Between 2014 and 2020, active treatment of periviable births increased by 3.9% per year. Yet, survival and long-term outcomes of infants born at periviable gestations are variable and uncertain. Depending on where you look for data, anywhere from 0 to 37% of babies survive at 22 weeks, 1 to 64% of babies survive at 23 weeks, 31 to 78% survive at 24 weeks, and 59 to 86% survive at 25 weeks. And we even have some individual unit data that have even higher numbers. Because of this uncertainty and this large variability, parents who are facing delivery between 22 and 25 weeks gestation are counseled on their options at the time of delivery, and they're asked to choose from full medical interventions to active comfort care. The AAP states that the primary goal of antenatal counseling is to provide parents with information that will aid their decision-making. And this counseling should include not only the expected outcomes for the infant, but also a discussion of available options. The specific counseling and the facts are left to the discretion of the physician. And that conversation, that perinatal dialogue, requires understanding and obtaining parental values and preferences, eliciting those values and preferences during the conversation. But not surprisingly, parents' values underlying making these decisions are complex, multi-layered, and potentially conflicting. For example, they don't want their baby to have pain or suffering, but they also want all medical interventions to prolong survival when that means doing potentially painful procedures. They want their doctor to not take away hope, but they also want their doctor to be 100% honest. And as physicians, we have a hard time clarifying parental values, and we may misinterpret parental perspectives. We really are not very good at identifying parents' preferences. In a counseling study, we asked participants to tell us what their preferences were before and after periviability counseling. Before counseling, 64% of enrolled women told us that they knew what they wanted regarding resuscitation, and 87% of them wanted full resuscitation. Clinicians told us 42% of enrolled women knew what they wanted, and that almost all of them wanted full resuscitation. Of those women who stated they had a pre-counseling preference, clinicians misidentified more than half of them as not having a preference. After counseling, 83% of enrolled women told us they wanted full resuscitation, and physicians told us 66% of them wanted full resuscitation. Of those who stated they wanted full resuscitation, clinicians misidentified a third of them as undecided or preferring comfort care or limited intervention. That's a problem. We really need to do better. We also need to acknowledge that we walk into these conversations with our own biases. There's large variability in prenatal counseling styles and medical interventions among different cultures, institutions, and individual clinicians. We have strong beliefs about who should and should not receive active treatment. And some of these beliefs may be due to our own religious or cultural differences. And we perceive death and disability differently than our parents. And these beliefs and attitudes may play a role in practice recommendations and influence our interactions with patients. A systematic review found that we're not in agreement. Anywhere from 4 to 47% of physicians would resuscitate an infant at 23 weeks, and 38 to 99% would resuscitate at 24 weeks. Individualized counseling may be biased. A national cohort of neonatologists were asked the likelihood they would recommend full resuscitation versus comfort care after being presented with a vignette of a woman in preterm labor at 23 weeks. 5 things were changed in the vignettes: her race, her age, her parity, her intendedness, meaning whether this was a planned versus unplanned pregnancy, and her education. Everything else was the same: fetal sex, fetal weight, complications, ultrasound findings, and whether or not she got steroids. Having a history of living children, an unplanned pregnancy, and Black race increased the likelihood of a recommendation for comfort care, while a history of pregnancy losses, a planned pregnancy, and white race increased the likelihood of a recommendation for full resuscitation. The author stated that the underlying bias was that some infants are more desired than other infants, and this may lead to subtle differences in how clinicians frame their discussions with families. And we know framing is important. We've known this for a while. This was a study that was published in 2008, where participants were presented with a hypothetical vignette of a threatened delivery at 23 weeks. The outcome information was framed as either survival with no disability, and this was considered the positive frame, or the chance of dying and likelihood of disability among survivors. This was considered the negative frame. Those for whom prognosis was framed as survival were more likely to elect resuscitation. In a more recent study, participants were given a hypothetical vignette of threatened delivery at 22 weeks gestation. Participants were presented with survival information with some detail about invasive procedures and average length of stay, and disability information. The order of presenting this information was randomized. Participants who viewed the survival pictograph first were more likely to choose intensive care than participants who viewed the disability pictograph first. So, an inherent bias may be communicated based on how the information is framed and the order in which it is given, and this bias may affect decision making. Despite a goal for non-directive counseling, neonatal physicians and nurses have paternalistic views. And there are many, many examples of this in the literature. So many surveys out there. And here's just one of them. All the neonatologists and the neonatal nurses at the 9 level 3 NICUs in Switzerland were asked about end-of-life decision-making in infants less than 28 weeks gestation. A majority of them felt parents should not be involved in end-of-life decisions because they might change their minds later and experience guilt. And parents should be spared the burden of making a decision. And parents were not in the right state of mind to make a decision. To me, this survey was very striking. And I need us to think whether objectivity is truly achievable given the biases that we all have. So let me go back to my original question. How do you counsel this woman? What information does she need in order to make an effective decision? A large systematic review of parental expectations and how healthcare professionals should interact with them showed communication style is fundamental. The quality of the consult was not purely about the content, but also the manner in which that content was provided. Key communication facilitators included clear, honest, and compassionate communication, caring and empathetic caregivers, continuity of care, and tailored approaches that reflected parents' desired level of involvement. Key barriers included lack of medical information and inadequate communication of information. Many years ago, I interviewed families of extremely premature infants, and I want to share two comments that highlight the importance of good communication. I had one mother tell me, "I know it's your job to choose your words carefully because you never know what might happen, but I think the best thing a doctor can do is tell the mother what's happening straight up. Don't beat around the bush because that doesn't help us. It puts false hope. It really does." I had another parent tell me, "I feel like the doctors need to be more honest right away and give us the worst case scenario along with the best case scenario. I realize they can't give us specific scenarios because they don't know. I just feel like they should be more honest because I know that when they have their meetings, they're honest with each other. They're not like that when they talk to us. They aren't. And I feel like maybe because they feel like we don't understand their verbiage. Well, that's what we need. Help us understand." And trust was a big, big issue with families I interviewed. When trust was lost, it was often due to miscommunication, a feeling that things weren't being said with certainty or that the doctors were hiding something. And when parents don't receive the information they need from the medical team, they turn to outside influences. There's a lot of information out there, and it influences how we interact with families. These families hear about miracle babies. Last year, the headlines presented a surviving 21-week gestation baby who is the new Guinness World Record holder for the most premature baby to ever survive. On Instagram and TikTok, there's an account dedicated to 22-weekers called 22 Matters. It was started by a woman who had 22-week twins that survived. To celebrate her twins' 5th birthday, the creator of this account posted a video of her twins with the words she says she was told when she was counseled about their delivery. She says she was told they'll never walk, they'll never feed themselves, they'll never talk. Is that the life you want for them? Just let them go. And I hope we can all agree that telling someone they'll never walk, talk, or feed themselves is the wrong way to communicate. And it's not how periviability conversations should ever be done. And politicians are diving into this. In 2021, a bill was reintroduced in Ohio that would require any infant that exhibits any movement or sounds or a pulsating umbilical cord or heartbeat to be provided aggressive, life-sustaining treatment. This bill didn't make it past committee, but it did lead to at least one hospital in Ohio requiring its neonatologist to resuscitate all 22-weekers at the time of birth. And there are other states that have proposed similar bills. And all of these outside influences shape our conversations with families. So again, let's go back to the case. How would you counsel this woman? How are you going to provide the information in order to support your patient's values and decision-making? Here's my bias. I am biased towards using decision aids to individualize counseling. In adult medicine, when there's a difficult decision without a clear right or wrong answer, doctors may turn to decision aids to help their patients make a decision. As with anything, the construction of decision aids is at risk for bias. So in order to minimize that potential for bias when presenting information, and in order to standardize the development of decision aids, the International Patient Decision Aids Standards Collaboration was established in 2003. The IPDAS has quality criteria for development of patient decision aids. I've outlined them here. It's 12 points with subheadings within each one of them. But essentially, the decision aid needs to be systematically developed, provide information about options, present probabilities in an unbiased way, help patients clarify and express their values, use patient stories, have a structured guidance in deliberation and communication, disclose conflicts of interest, have a balanced presentation of options, use plain language, base your information on up-to-date scientific evidence, which should be obvious, establish its effectiveness. And then there's additional criteria if it's an internet-based decision aid, though most of them are not. More than 500 decision aids have been developed worldwide, and there's evidence that they increase patient involvement in decision-making about their healthcare. They're not meant to replace patient-clinician interactions, but they're intended to act as a supplement to patient-clinician conversations. Compared to usual care across a wide variety of contexts, people who make decisions using a decision aid feel more knowledgeable, better informed, and clearer about their values. So when I started thinking about creating a decision aid to support periviable conversations, we realized we needed to consider the following. What information needs to be communicated, and how should that information be given? Let's start with the first one. What information does a woman need to have in order to make an effective decision? There is so much information one can cover when having a conversation with an expectant mother. Here is but a glimpse of things that I have seen in my fellows' notes. Every year, I give a talk on periviability counseling to the incoming first-year NICU fellows at our regional boot camp, and I show them this slide. And I then beg them to please not monologue at parents. When I interviewed women who had had an extremely premature infant to find out what they would have wanted to know at the time of counseling, they told us 4 things. They wanted to know, what will my baby look like? Will my baby survive? If my baby survives, what will he or she be like later on? And what are my options? That's what it boiled down to. The amount of detail within each one of those questions varied from person to person, from family to family, but essentially these were the 4 items they wanted to know. Knowing that some families wanted data, they wanted numbers, we asked ourselves, how should we provide this information? What is the best format to present numerical information? And I'm going to geek out a little bit when it comes to numbers and presentation of numbers. There are several ways one can communicate risk to patients. Here are some potential formats. Here you have an icon array, a table, a pie graph, and a vertical bar graph. And they're all presenting the same information, that the risk of something is 36%. And when you think about what format is appropriate for your patient, it is much more complex than one imagines. It is actually very complicated. You need the format that you want to use depends on what you are hoping to facilitate. Do you want your patient to identify the right number? Do you want them to recall a number? Do you want them to be able to differentiate between 2 or more numbers? Do you want them to categorize the number? You also need to think, does the format impact behavior? Is the way a number is presented intended to make the patient want to do something? And does it actually make the patient do something? Does the patient like the way the number is presented? And does that make the patient do something? Does the patient trust the number that you're presenting? And is there behavioral motivation and an ability to choose? There is no communication format that is best at achieving all possible outcomes or that is superior across all the tasks. When we looked at potential formats, we went looking for probability formats that assessed point tasks. So these are tasks that require interpretation of a single probability. For example, the chances of survival. We found that point tasks are best understood when they're presented as an icon array. We also found that the type of icon in an icon array matters. People will recall a number better if it's presented with little figures, such as people, over a plain format. Numerator-only presentations, such as this one, where you have 10 icons, may affect probability perceptions more than presenting a single number, more than presenting a 1 in X format, and are better than icon arrays. However, if a number is placed next to an icon array, this combination is preferred over a numerator-only presentation. So, putting all of that together, we iteratively developed a 6-card decision aid. In the first 3 cards, we addressed the 3 major items women told us they wanted to know. What will my baby look like? Will my baby survive? And if my baby survives, what will they be like later on? In the first card, there's an image of an extremely premature child to illustrate the size, and a picture illustrating what that child may be attached to when they are born. And here the doctor can talk about what may happen in the delivery room. The next 2 are icon arrays representing survival rates at 4 different weeks of gestation and the chances of having 1 of 4 serious long-term problems at 18 to 22 months of age if you are born at less than 1,000 grams. Purposely choosing to present information by gestational age in one card and by weight in the other. And you'll notice that the survival card and the long-term disability card are framed differently. And that was on purpose to decrease bias towards a positive or negative decision. We also thought about the use of color and how that may impact positive or negative framing. And we listed a series of words at the bottom. This is in our initial draft. Race has since been removed. And we, the words down here are meant to be prompts for the counselor to talk about how these impact survival or how they impact long-term outcome. Something unexpected and interesting when we developed the decision aid was that when we tried to present the range, so for example, at 22 weeks, the range of survival being 2 to 9%, when we tried to present the lower end of that range, families didn't see it. They only ever saw the higher number. We tried different shades, different size, and they only ever saw the highest possible number. So we chose to outline the average in black in the hopes that this number would stand out a little bit more. As part of this project, we also interviewed clinicians and nurses about their experiences with prenatal counseling, and they agreed with what the women had said about what they wanted to know. But they also thought that in order to understand long-term outcomes, women needed to understand the impact of short-term morbidities on long-term outcomes. And so we made 3 cards that focus on the 3 morbidities that we know impact the chances of long-term neurodevelopmental impairment: BPD, IVH, and ROP, and we used simple language and pictures to explain complicated concepts. We didn't explicitly address the question, what are my options? The cards are not meant to be used in isolation, but they're meant to be used as a foundation for a deeper conversation about options. There's no card that actually presents the options. There's no set order in which to use the cards. They're meant to be individualized based on what families want to know. Some families want data. Some don't want any numbers. Some families don't want to see any card, and some only want to see the first three. Some families want to see all six and then ask for more. We validated the decision aid using simulated counseling sessions, and we found that it facilitated conversations and the transfer of information. We similarly asked, what do Latin American parents want to know? And after interviewing Latin American women, we found themes that paralleled those we found in our English-speaking population, and we were able to do a direct translation of the original decision aid. We then considered a completely different format. Parents in our interviews had told us they wanted to hear from other parents, so we made a short movie with 6 parent-child dyads. And we tested the final version of this movie in simulated counseling and found that it provided people with insight into what life with an extreme premature child was like without inducing stress. We then conducted a multi-center randomized controlled trial where clinicians at each site were randomized to either counsel women using the decision aid or counsel them in their usual manner. And the study showed that the decision aid improved knowledge and that families found the decision aid useful. And we received a lot of useful feedback. Parents commented on a desire for a tailored approach to antenatal counseling. They noted the importance of engaging different learning styles and commented on the benefit of using a visual aid for those who were in the decision aid arm, or commented that they wanted a visual aid for those who were in the routine counseling arm. They asked for more clinician sensitivity, and they wanted more recognition and support of their values. They wanted hope, comfort, and optimism. Clinicians told us they liked using the first 3 cards. And then they told us they infrequently used the BPD and IVH card, and they almost never used the ROP card. Both parents and clinicians asked for a combined long-term outcome card rather than having each of the 4 components of NDI listed. So with that feedback in mind, we realized further individualization was needed. We also realized the difficulty of maintaining the data up to date when one has physical cards. So we hypothesized that combining all of these decision aids into a unique web application could improve the quality of counseling and help families make informed decisions consistent with their values. So we set out to make a web-based decisioning. It has 3 components: an outcomes calculator, so our data, a values clarification exercise, and movies where parents provide advice. For our outcomes calculator, we wanted to incorporate the components we know impact survival: gestational age, birth weight, infant sex, and antenatal steroids, and whether it's a singleton versus a multiple pregnancy. We used our own internal database and combined it with data from the NICHD survival calculator. And we went through several iterations of this calculator, including different options for the user interface and different styles of the output. And then we got a lot of feedback as we went along from an advisory panel, and ultimately came to this final version where the user enters what is known about the pregnancy, such as the gestational age, the birth weight, the infant sex, whether or not mom got steroids, and whether or not it's a singleton birth. And the output provides the estimated chance of survival and the estimated chance of long-term problems using the same icon arrays in the same style as our original decision aid. We included the range at the top, and we put them side by side since this was the preferred format. You can see that we also combined the long-term outcomes into one icon array. And at the bottom, you still have a prompt to discuss the impact of short-term morbidities on long-term outcomes and a link that takes you to additional information, if desired. Next, we focused on a values clarification exercise. So the process of clarifying and expressing your values is an important aspect of shared decision making, and it's one of the quality criteria from IPDAS. Values clarification can be implicit or explicit. In other words, you can ask a patient to think about what's important to them, and through that conversation, you can figure out their values, and that is considered implicit. Or you can ask a patient to complete a task, and the act of doing the task helps them clarify what is important to them. Recent literature in the last 5 years in medical decision-making suggests that decision aids should include an explicit clarification values clarification method rather than using an implicit method. The literature shows us that those who use explicit values clarification methods are more likely to make decisions that align with their stated values and are less likely to have decisional regret. So we set out to create an explicit values clarification exercise. And we started by creating a list of potential factors that play a role in decision making. And these were obtained from a systematic review that was published in 2018 that explored parental perspectives regarding the antenatal consult and had done thematic analysis of these perspectives. We included these factors in a survey of women who had experienced an extremely premature delivery and asked them to categorize them by their level of importance. And 242 women validated our list, with a majority of women rating each of the listed individual factors, some number of them as highly important. We took each one of those factors and created a list of statements and assessed each statement for face and content validity. And then finally, with the help of a neonatologist in my group, who is also a board-certified palliative care physician, we took each of those statements and turned them into I hope and I worry statements. So for example, the statement, what's important to me, my baby's chance of survival, became, I hope my baby lives more than anything. I worry about what my baby will go through to live, and my baby's life is worth living in any form. Another example was, what's important to me, my baby's chance of development problems later in life became, I hope my baby is healthy and lives someday on their own without problems. I worry about serious problems my baby might have. I worry that my baby's life might be hard. When we put them together on our website, we created this task, and I apologize, there's a typo here. The user is prompted to drag and drop each one of these sentences into one of the 3 boxes down here based on the level of importance. And once they're done, they can capture and download a screenshot of their answers, which they can then share with their doctor. And then the last part was hearing from other families. We had previously seen that we could do a movie that had families in it that did not induce stress, and that could be very useful for families. So we put together a film crew and went directly into people's homes and obtained interview footage as well as footage of the families. We interviewed Danielle. Her daughter is Delilah, and she was born at 22 weeks and is now 4 years old and has mild developmental differences. This is Heather, and her son Gage was 22 weeks at birth and is now 9 years old. He is legally blind, so is classified as having moderate developmental differences. This is Kieran and her partner Dylan. They had a 23-week infant who died after a redirection of care in the delivery room. And they then had a 22-week infant who survived and is now 4 years old. And this is Roberto. He is 4 years old. He has a trach and a G-tube and has severe developmental differences. It was immediately evident after we filmed our 4 families that we had a diversity problem. We had identified these families for the movies with the help of a member of a parent organization for preemies, and these were the parents who volunteered. We were unable to recruit a family who chose non-intervention. We had one potential family, but at the time that we went out to film, they needed time to think about it. And so we could not get them on camera. And we also had more what's considered, I guess, traditional mom-dad family structures. We did find an opportunity. Angela's first language was Spanish, and so we conducted her interview in English and in Spanish, since that is also my first language. And we found that we had so much incredible footage that rather than doing one group movie, we thought it would be better to create individual long movies. After a few months of searching, our crew reconvened. We found 2 additional families. This is Paola. Her daughter Kalani was born at 23 weeks and is now 3 years old, and she has a trach. Paola was a teen mom. She's single and lives with her mother. And this is Colette. Her daughter Callie was born at 22 weeks and is now 19 months old. So we were able to improve our diversity problem. 3 of our 6 families identify as visible minorities. Unfortunately, the family who chose non-intervention, we went back to them since some time had passed and asked them if they wanted to participate, but they did not want to go on camera, though they offered to participate in an audio-only interview. And we considered it, but ultimately chose not to record them that way. We didn't want the perception that choosing non-intervention was a negative choice that needed to be hidden. We did a lot of editing to minimize bias. We tested different versions of the women, we changed the order in which they were presented. We also, once again, ended up pivoting from creating 6 long individual movies. We were in the middle of editing the second long movie, specifically Angela's movie, and we realized that without the balance of the other women around her, her video could be seen as biased. So again, we pivoted and we created 3 short group movies where each woman answered, what advice would you give another woman or family who is in the same situation you were in? What do you wish the doctors had told you? And what influenced your decisions? We received feedback on these movies from members of our advisory committee and from lay community members, and the movies were really well received. And I'd like, if I'm successful, I'd like to play a little clip of the movie so you can see one of our finished products. Are you able to hear it? Can I get a thumbs up? Are you guys able?
Actually, I don't hear it this time.
We don't hear it. Oh, we
Oh.
tried it. Give me a second. Let me try. Give me a sec. Let me try this again. I apologize.
I could get their mom or family in the.
How about now?
My name is Danielle Christensen, and my daughter Delilah was born at 22 weeks and 0 days gestation. The best advice that I could give another mom or family in the same position as us would be to follow your heart. There is no right or wrong decision in this. Both are hard. Losing your child is extremely hard, and one of the most devastating things that I have been through, as well as going through the NICU journey. It's traumatizing and it's hard, and there is no right or wrong answer to anything, and just do what is best for you. I think one of the most important things was being involved in her care. I did almost every diaper change. I was there during every shift change. I held her as much as I possibly could whenever I was allowed to. And I think those things were hard. And I wish to tell people to be kind to yourself, that this is an extremely overwhelming time. And it's hard to not feel that mom guilt and to be kind to yourself, because it will pass. It will pass when you see them smile. It'll pass when you hear them cry for the first time. It will pass when they are 5 years old and running around and telling you that they love you so much.
My name is Angela. I am Roberto's mom. My child was born at 23 weeks and 6 days gestation, and he's 4 years old now. My advice for families who might be in this situation, standing this journey, is that first you are going to cry a lot. It's gonna be a roller coaster of emotions, but it will pass. It will pass in the sense that these little kids are so resilient. They are going to witness some things that you never thought that your kid will be able to do. And then it's gonna be a challenging life, but it doesn't mean that it's gonna be an awful life. It's gonna be a beautiful life. It's depending how you see things. And it will change you the way you think and appreciate every single moment of life. And it will teach you to be such a strong person. You will become a different human being. You are going to become to appreciate every single thing you kid does, like walk or put your hands in put the hands in the mouth, or just giving you a smile. You are going to never take anything from granted, and one day all these tears are just gonna be tears of happiness, and you will not regret your decision, and you will learn to live a different life that is gonna be beautiful, and you are going to do it all over if you are put back in the same spot, because you learn to love that little human being and respect that little human being so much that will teach you to be the strong that you might not be at this moment. That's all.
I'm going to pause there to continue. Our website doesn't have a structured way to use it. The landing page is more of a choose your own adventure. The layout allows a parent to start wherever they prefer. You have tabs at the top if you want to go to values exercise or look at the videos. You also have links directly here. And the website also includes our original Decision Aid cards. If a clinician would like to use or print any of the cards, the website is available in Spanish. The movies are obviously not in Spanish, though we are working on adding subtitles. And the Decision Aid, this website can easily be used on the laptop, tablet, or phone. Our lay community members have assessed the website for design and color, progression and display of content, the graphics, language, and tone to maximize sensitivity, neutrality, and clarity. Our next steps are to continue refining the website through ongoing feedback and then conduct acceptability testing with women who are admitted to labor and delivery and the periviable window. Ours is not the only decision aid out there for periviability. This one is by Gregory Moore, a neonatologist in Ontario. You'll notice that it looks very similar to ours because he asked if he could use ours as their starting point, and we said yes. He did have a specific card to discuss options. You notice here palliative care is an option. And he created individual cards for each week of gestation rather than grouping them. So there are a lot of cards, but they're not all meant to be used at once. Since the majority of adults have a smartphone and use the phone to get health information, Olivia Kim and Mir Bazir in Wisconsin developed an app for parents with risk factors for premature birth, and they're meant to use it starting at 18 weeks. The idea being that you tackle the problem ahead of time so that a woman has time to think through what's important to them and what might they want if they get admitted in the periviable window. You'll notice that they also have babies for icon arrays because Mir also asked if he could use our icon arrays to do his app, and we said yes. And finally, most recently, Brownson Tucker Edmonds, an OB at Indiana University, systematically developed a decision aid application that provides survival estimates, neonatal outcomes descriptions, and explicit values clarification exercise. And a randomized controlled trial for this decision aid is currently underway. To date, the use of these decision aids have been well received by families and may improve some of the issues seen in periviability counseling. So in summary, there needs to be a thoughtful commitment to enhancing true shared decision-making. As we strive for a less biased, more transparent process, we need to recognize that we all have inherent biases that impact risk prediction and values-based decision-making. Values-based counseling may be possible using tools such as decision aids. They provide a way to present information and facilitate a dialogue to elicit parental values. Further testing of a web-based decision aid is needed to see if it similarly can provide support for families facing periviable deliveries. And I'd like to leave you with a quote which I think is very applicable to periviability conversations with families. People will forget what you said, but people will never forget how you made them feel. Thank you. I'll take any questions if you have them.
Thank you so much, Dr. Guillen. What a great presentation. It opened my eyes to the world of decision aids, which I guess we don't have in a formal setting at our centers. The chat box is open, and anyone would be welcome to type into the chat or to unmute and ask a question out loud too. One of the things that I thought of early in your presentation was about